It's time for gout. It's a classic. Yeah. I think I'm going to become a pot-smoking vegetarian. I'm going to become a pot-smoking vegetarian, and I'm going to avoid the gout. Why don't we pronounce it gout? I don't know. But it's gout. All right, a man's got right knee pain. Began suddenly awoken from sleep. Yes, it's horrible. And there's a fever, and it's red, swollen, warm, and tender. And that's because it can look just like a person who has septic arthritis. Hot, red, warm, swollen, tender. 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 Rhubarb, Doloc, Calor, tumor. Aspirate. And you're going to aspirate because gout here can look just like a person who has septic arthritis. Can look just like it. And it's the X-ray most of the time doesn't show anything. If it's chronic gout, you can show sort of a rat bite eaten appearance. Calcium pyrophosphate deposition disease can show some calcifications in the synovial cartilage, in the articular cartilage, but most of the time it shows nothing. Now, if they definitely want you to know it's infected, they tell you it's above 100,000 cells. If they definitely want you to know it's not infected, they'll say it's less than 20,000 cells. Now, if they don't want you to know and they want you to do crystal analysis, they'll tell you it's in the middle, like this, 23,000 cells. 23,000 cells is in the middle. 23,000 cells means I don't want you to know. 23,000 cells is in the middle, I don't want you to know. Under 20 is definitely uninfected. Over 50 is probably infected. But this person, because of negative needles, that's what makes this gout. Because gout has negative needles, pseudo-gout has positive rhomboids. I always wondered, you know what that word rhomboid means? Rhomboid means it's not a needle, it's not a triangle, it's not a square, it's not a circle. Rhomboid is everything else. That's how you know it's gout. Now, here we go. The initial therapy. The initial therapy for treatment is, for gout, is now, and has been for the last couple of years, to use first, non-steroidals. First is non-steroidals. Now, it definitely does not have to be indomethacin, and I'm saying ibuprofen just because it's common. I could have said naproxen, Sulindac, meloxicam. I could have said any of the non-steroidals first. So the initial therapy is one of the non-steroidals. Which non-steroidal? Couldn't tell you. Any one of them. Now, colchicine should not be used for acute gout first any longer. It's an amazing thing, really, isn't it, that colchicine, after all these years of being generic, colchicine becomes a drug that becomes a manufacturer's name after all of these years? Wow. It's amazing, isn't it? Allopurinol and febuxostat are xanthine oxidase inhibitors. And allopurinol and febuxostat should never be used in acute gout. Allopurinol and febuxostat should be used to prevent the next gouty attack, but never during acute gout. Intra-articular steroids are useful if you have a contraindication to non-steroidals and you have one single joint. Intra-articular steroids are fantastic, and they are a very legitimate form of treatment for gout. Where people got into trouble with intra-articular steroids with fungal infections is using it for bursitis and tendinitis, not for gout. You see, that's not where people got into trouble. They were overusing the intra-articular steroids and using specially whipped up, home-brewed, compounded stuff that got contaminated with fungi. But that thing about intra-articular steroids, or shooting it up into joints like into the spine, that was not a gout thing. That was a, I got low back pain, I have tendinitis, I have bursitis story. Febuxostat is a xanthine oxidase inhibitor. Febuxostat, and I hate to use trade names here, I remember I never, here's a matter of full disclosure, Dr. Fisher never speaks to drug companies ever, but some of you know it as Uloric. Remember, trade names are not on the boards, and neither is dosing. Dosing and trade names is not on boards. So you must relearn it. If you're used to only thinking about it as Uloric, you've got to learn it as febuxostat. So I'm not telling it so because you've got to know the trade name. I'm telling it so that you can retranslate it so you know what the hell we're talking about here. After all, it's on TV. Allopurinol is not during acute episodes. It's to prevent the next episode. Intra-articular steroids is when you can't use nonsteroidals. Colchicine is not for acute gout anymore. We can use it prophylactically. Oral steroids or IV steroids is if you have a contraindication to nonsteroidals and you have multiple joints. If you have multiple joints. In other words, if it's single, give it a shot. If it's multiple, give it a swallow. Now, oral steroids are the answer when you have a contraindication to nonsteroidals and multiple joints. Multiple joints. Colchicine is the answer too. I want to make sure these are crystal clear. That's why we're doing this twice. They're preventive. It's preventive. It's preventive. Preventive. And it's not first line for anything in gout. We can use it for familial Mediterranean fever. We're always seeing that, of course, every day, morning, noon, and night, familial Mediterranean fever. So colchicine can be used for FMF, but not for gout first. Not for gout first. Now, the non-pharmacologic methods are basically alcohol really does cause gout. And when I make a joke about saying you need to become a pot-smoking vegetarian, that's pretty much true. You do need to become a pot-smoking vegetarian because alcohol definitely causes gout. Now, the other thing is no red meat, no organ meats, no beer in particular, because beer is the worst. Beer is the worst of all of these. Beer is the worst. Beer is the worst of all of these. These are just as important as the medications. Now, the indication to use drugs for uric acid levels, okay, let's put it this way. If you have a gouty attack and you have high uric acid, you should be using allopurinol or febuxostat to prevent. Sulfenpyrazone and probenecid are old drugs that increase urinary uric acid excretion. Probenecid are to prevent. All of these are prevention only, and they're only after acute episodes. Remember, none of these are supposed to be used during an acute episode. And probenecid and sulfenpyrazone, I'm this close to just saying never. However, technically you can use them for some people, but they would be like this. You didn't get better with allopurinol? Try febuxostat, xanthine oxidase inhibitor. You didn't get better with febuxostat? You can use colchicine to prevent. You're on febuxostat and colchicine or allopurinol and colchicine, and you're still having recurrences? Probenecid, sulfenpyrazone, third or fourth line. Febuxostat is prevention. It's an alternative to allopurinol. And remember, there's a lot of people who are allergic to allopurinol. Tons. So this thing about using febuxostat is not far away. There's a lot of people who have allergic interstitial nephritis, have rash, renal hemolysis from allopurinol. It's an alternative. They decreased uric acid levels by inhibiting the production of uric acid. Remember that these inhibit production of uric acid. What are the names of those drugs that increase the destruction? What are those drugs that increase the destruction or the loss of uric acid, the breaking down? Rasburicase and pegloticase. Rasburicase and pegloticase increase the destruction of uric acid. Those increase the destruction. Pegloticase, rasburicase, uric ace. So guy's got a history of gout, peptic ulcer disease, he's got chronic renal insufficiency. And he's got some gouty gout, gout. Now, what are you going to do for this dude, okay? Because this person's got lots of contraindications. Nonsteroidals is bad when you got peptic ulcer disease. Nonsteroidals are bad when you got renal insufficiency. Is it multiple or single joints? It's a single joint. Shoot 'em up, baby. Shoot 'em up. Multiple joints, systemic steroids. Single joints, intra-articular steroids. The guy's got a markedly elevated uric acid level, and the urologist, for a reason, I don't know why I can't. Why did I get there? I can't remember. I must have gotten it for some reason, other reason. So what do you want to do for a person who's got, he's asymptomatic. Oh, there it is. Welcome to rheumatology. An asymptomatic blood test in rheumatology always equals do nothing. Never treat an asymptomatic hyperuricemia. Never treat an asymptomatic hyperuricemia. Never treat an asymptomatic hyperuricemia. Leave it alone. Leave it alone. Leave it alone. Leave it alone. A 43-year-old man's got pain in his knees and his wrist, and he's got some erectile dysfunction. All his joints are weak. Swelling of the wrist and knees, calcification. Ooh, calcification. Calcium pyrophosphate deficiency. Calcium pyrophosphate deposition disease. Calcification of the menisci. Calcium pyrophosphate deposition disease. Liver dysfunction. Liver. Joint. Liver. Joint. Liver. Joint problems. Erectile dysfunction because you've got iron building up in your pituitary. Iron building up in your testicles. What is it? It's calcium pyrophosphate deposition disease from hemochromatosis. Iron built up in your brain, in your joints. Iron in your skin, bronze diabetes. Iron in your pancreas. Iron in your heart. Iron in your liver. And what's the most common manifestation of hemochromatosis? The most common is actually liver dysfunction. What's the most common cause of death? Liver dysfunction. What's the most common cause of death from hemochromatosis? Is liver dysfunction. That's the most common. Liver. 80% of people who die of hemochromatosis die from liver. 60% cirrhosis, 20% hepatoma, liver, not heart. That's the most common. Wrong answer. It's only 15% heart. I know what you're thinking. Sarcoid, amyloid, restrictive cardiomyopathy, hemochromatosis, cancer, and fibrosis. Yeah. Sarcoid, amyloid, hemochromatosis, cancer, and fibrosis. Yeah. The cause of restrictive cardiomyopathy may be sarcoid, amyloid, hemochromatosis, cancer, and fibrosis. However, even though it's a cause of restrictive cardiomyopathy, the most common manifestation is liver dysfunction, and treat it with phlebotomy. Phlebotomy. A 58-year-old woman's got joint stiffness. A year ago, a year of a stiffy. And not too long. That's, by the way, how you know it's not rheumatoid arthritis. Rheumatoid arthritis goes on for a long time. Me stiff you, long time. Rheumatoid arthritis, long time. Rah, rah, long time. Rah. So distal, also not rheumatoid arthritis. Knee, not rheumatoid arthritis. Well, now, gradually worsens, but the injury, this is crocheting. Somebody said to me, what do you mean when she touches her crotch? It's not a crotch, you disgusting person. I can't hate people who talk like that. Crotching. Crocheting, it's like knitting. This is an overuse injury, crepitus, overuse injury. And this is osteoarthritis. That's osteoarthritis. It's osteoarthritis. It's an overuse injury. Now, what do you get on an X-ray with osteoarthritis? X-ray. Well, what is articular cartilage made out of? What's articular cartilage made out of? The primary constituent of articular cartilage. The major constituent of articular cartilage is water. And when the water goes away, the joint looks like it gets closer together. But the major constituent of articular cartilage is water. That's the major constituent of articular cartilage. So when you lose articular cartilage, the joint space narrows. In addition, You get osteophytes because osteophytes is the joint extends outwards to try and give more surface area to support the joint. The joint space narrows, and osteophytes is an exaggerated widening of the joint. The joint space narrows because my joints and your joints and normal joints, articular cartilage is mostly water. So since articular cartilage is mostly water, when you lose it, it looks like the bone gets closer together. Osteophytes is outcroppings of bone on the side. Now, you might say, well, how many questions can you get on osteoarthritis? Not that many questions to get. You're right, there aren't. There aren't. But the ones that there are, you got to know. For instance, what test is there? Okay? What test is there? Which of these goes up in osteoarthritis? None of them. Ferritin goes up in nothing really. It's up in hemochromatosis. It's up in Still's disease. Remember Still's disease? You're still the one. I make my ferritin. Still the one. I got reactive arthritis. Yeah. And rheumatoid factor, well, anybody can have rheumatoid factor because rheumatoid factor can be falsely positive. The same way you can walk down the block, and 1 out of every 20 people down the block can have a positive ANA. I can go to Grand Central Station and find 10,000 people a day who have a positive ANA. That doesn't mean anything. There's nothing there. Now, in the non-pharmacologic interventions, and again, I get jealous every once in a while when I see TV docs, and I'm like, man, how come I don't have my own show? I want my own show. I'm inadequate. Oh, my God. And then I realize what they have to do, and they have to talk about morning, noon, and night is overweight, weight issues. And it's an interesting thing that they're talking about weight issues to people who are sitting at home not moving. But that's the paradox, right? But if you have to carry around 50 more pounds than I do, and we both have the same joint, your joint's going to wear out. For instance, I'm 6'4" and 220 pounds. But I got friends of mine who are my height, and they're 320 pounds. Well, their joint's going to wear out first. You got to lose weight. The other thing is, the stronger your muscles are, the less work your joint has to do. So that thing about exercising, this is not bullshit on this. This is real, man. If you, for instance, as a big guy like me, I avoid going on distance running because I know I'm going to ruin my knees. Eventually they'll wear out. And so I don't do it too much. Cycling, swimming, cycling, swimming. The stronger your muscles are, the less work your joint has to do. The stronger your muscles are, the less work your joints have to do. And that's why if you've got back pain, do abdominal exercises. The stronger your guts are, the less work your back has to do. The stronger your abdominals are, the less work your back has to do. And that's why the weight loss really helps. Because if you have stronger muscles carrying around less weight, your joint's not going to wear out as much. You're going to take the wear and tear off of it. Now, the initial therapy, now this may seem like a small question to you, but it's not. It's a colossal issue. What do you think? Well, most of rheumatology, haven't we said all day, night, or whenever you're listening to this, haven't we said to use nonsteroidals? But not in osteoarthritis. I'm going to tell you why. Osteoarthritis is a chronic, lifelong problem until you get your joint replaced. Now, joint replacement is fantastic. There's about over 100,000 knees done a year in the country, and you can get up the next day and stand up. And so I would do it myself if I had to have it done. Matter of fact, yeah, I would. But until such time as you get your knee replaced, you're going to need these drugs a lot. And daily indomethacin, you might as well drink Drano. You might as well drink liquid plumber. 20%. What's the incidence of ulcers at a year on nonsteroidals? For every 100 people who take nonsteroidals every day, 20% of people at a year will have 20% of people at a year if you take non-steroidals. And not just that evil crap of indomethacin, by the way. Not just that evil indomethacin, but any non-steroidal. Ooh, look at that. I'm still on. What do you know? So any non-steroidal, not just indomethacin. And coxibs are a fraud. Ooh, that sounds harsh. They're a fraud. They're not any better. We thought that they would do less adverse effects, but they don't. They don't. They're not really any different. And acetaminophen has the same pain relief without the ulcers. Remember, 20% will have an ulcer. 10% of them will have symptoms. 5% of people will bleed. So for every 5 people you treat with a non-steroidal daily, 1 gets an ulcer. For every 10 people you treat, they'll have symptoms. For every 20 people you treat, you're going to make them bleed. Weight loss, exercise, acetaminophen, joint space narrowing. Have a nice day. Next one. A man's in the emergency department. He's got right knee pain. And it began suddenly. It's dull in character. And it's got, okay, but there's no weight loss. It's local. He's got some asthma. It's local. It's taking prednisone. Ding, 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 ding. Joint pain with prednisone, joint pain with prednisone. But he's got pain on internal rotation. Ooh, sudden, neat, Jojo. Avascular necrosis. Okay, avascular necrosis. Okay, hip knee, yeah, avascular necrosis. And that's because the avascular necrosis, X-ray first, MRI best, avascular, okay, X-ray first, MRI is best, X-ray first, MRI is best. And the treatment, calcium, vitamin D, and bisphosphonates. It's not a complicated disorder. The complicated disorder is that knowing that you're going to be using steroids is a reason to screen for densitometry. Chronic steroid use. You see, in a 50-year-old man, you won't be screening for bone densitometry. In a 60-year-old man, routine bone densitometry is not in men. Routine bone densitometry begins in women at the age of 65. Routine bone densitometry begins in women at the age of 65. Routine bone densitometry not in men. Ooh, but what if you're on steroids? Yeah, I'm telling you, steroids are a disaster for the bone. They're a disaster. X-ray, MRI, calcium, vitamin D, bisphosphonates, and screen men who are on steroids for bone densitometry because it is a disaster. See you in the next section. It is a tremendous thing to have the opportunity to study and learn, isn't it? It's tremendous. You have to have something before you can give. If you don't have, you can't give.